Just to remind everybody of the ambulance service, it's 1.8 billion, which is a relatively small amount considering the national English budget is about 120 billion, 40,000 people. But it is actually one of the narrows in the system, and the more we can run it better, it has a much scaling up effect. So if you, at any one time, if you froze the population, the acute hospital population, 40% of those people would come in an ambulance. So it's clearly, if you can flex that, the thing is, I think the two main things that came out of it really were the variation between those trusts who convey, i.e. take people to hospital. So the highest was about 64%, and the best was 52%. And there's a huge delta there in that. And the second thing was significant unwarranted variations in the operating costs and practices of the trusts. And those two things together, if we could correct them, so on the conveying point, with other work that's going on urgent care centres, and if we're able to do more, as Andrew was describing with his drop-in centre at Aldershot, if we could do more to divert particularly mental health psychiatric cases away from hospitals to places where they can just be talked to, it would be enormously helpful. I think why then do some trusts succeed?
Luke, welcome. Come up to John's.
This is Luke, who's done all the work, who works for Jeremy Ryan. I'm just saying the two blocks, the conveyance point and the unwarranted variations in the operating costs. And I think outside the meeting, Richard said to me, well, what can we do therefore about the difference in the conveyance rates? Why have some people got are better at actually essentially triaging? And I think it comes down to three factors: the training of the teams. If you've got confident diagnosis, it's the point we were talking about this morning. If you've got confident clinicians, they will actually admit less. I mean, we saw that in the junior doctor strike, and we see it here. And there's probably, in terms of controlling hospital admissions, that's the single most important point. If we can actually make those people on the front end really confident and make the right decisions, then I think it's there. And I think that comes down in various areas. It's a simple thing about management and how you run your workforce. And one of the striking things about this workforce is the high level of sickness. So you've got 20 days a year. The average in the NHS is 13, and that's high by anybody's standards. I mean, I think most people, I think we had a conversation once, I think at Mass General you'd have the drains up at 5, wouldn't you? Yeah. So, I mean, that's a problem that we've got, and I think it plays through to the thing we're going to have to address, which is this question of high levels of bullying and harassment.
Yes.
And why do, I mean, in a sense, you on the face of it, we take a lot of trouble to be courteous, to respect the independence of Foundation Trust, respect all those things, and yet when we get the surveys back, people appear to be telling us something else. So I mean, I'd leave that on the table. But where you have got management which really understands its workforce, and actually it's a very tough job. I mean, you're turning up at a crash, you're turning up at actually somebody's house where they're really ill and they're on the floor, they're in pain. These are very stressful jobs, and the support we give to these people is really critical. And if you look at the rising status of paramedics over the last 15 or 20 years, they're actually beginning to get the recognition they deserve, because they are absolutely the front line. And the more recognition we give them, it's critical to do that. And then the question will be, it's a scarce resource, how do we deploy it? And over time, how do we add to it to make that the case? And then on the unwarranted variations, it really comes down to a couple of things. One is the use of technology. And you would not think we were in the digital age if you entered some of the ambulances. I mean, you can pick somebody up and you can't access the record in most parts of the country, and where you can, it's slow or it's difficult. So essentially, we're conveying people blind. And when they get to the hospital, and a little sort of vignette about this, it's the lack of joined upness. So one particular ambulance service, a very simple thing, when they were doing ECGs on the patients, they stick the stickers on, they arrive at the hospital, and the hospital rips them all off because they've got a different ECG system. And so it's little things about workflow and how that workflow passes through the system, and people are being made aware of it. And I think I'll conclude by saying the challenge we face as NHSI is how do we take that best practice? How do we take the knowledge of reducing conveyance, and how do we take the knowledge of actually really triaging effectively and spread it throughout the system? And I suppose the comfort is that we've got people doing it really well. So this is not a systemic national problem. This is a problem of the fact we have not yet developed the skills of transferring, and then to meet our job description improvement, we've not yet developed the skills to take that improvement and shift it. And we need to do that both on the conveyance and on some of these sort of variations in costs. And I'll leave with a simple example of little simple things like payslip costs on the back. I mean, it is, to me, why would we accept that some ambulance costs, trusts are paying like £4.30 or £4.40 to process a payslip, when we know nationally people are getting it for £3.02. It's little things like that that I hope in the new regional structure that we'll have the mechanisms to help people, not to sort of, beat them up, but to help people and point these things out and to do that. So I think that is on the main points, but I'll leave it to Luke, who, as I said, done most of the work and who I owe a lot to. And also to the comms team, by the way, who've done a great job on this.
They have, thank you.
Thank you, Patrick. I was just going to add a couple of very short points. First thing I want to say was thank you to the Ambulance Trust, and formally suggest we recorded that at this board. They put in an inordinate amount of effort, energy and data, and were incredibly patient with the team as we worked out how ambulance services work. So I think that's important to record. The only things I want to say really in additional to the points that Patrick made is really around implementation. And just to let you know, we've made a start on that today, and it's a first step. So we launched the ambulance portal this morning at 10 o'clock. That went live to all ambulance services, and we got about 300 to 400 metrics up, which includes data that we previously not nationally shared. It's a very first step, probably akin to the Model Hospital launch a couple of years ago, but I think it's quite an important moment for us with the Trust, so we're hoping to get quite a lot of uptake on that. And the final thing around is the body of work that needs to go into the implementation. There's quite a number of quite significant recommendations for the service, particularly around fleet and consolidation of fleet, and around control centres in the long term with the implementation of the Emergency Services Mobile Communication Programme, which the Home Office are leading. When that sort of new infrastructure gets built, I think there are some quite potentially significant changes we'll need to work on with the ambulance service, which will have cost implications, both in terms of infrastructure investment, but potentially long-run savings. So there's quite a significant programme of work, but I'll probably leave it there at this point.
Richard?
Thank you very much. I mean, it was a really interesting report in an area that we don't often look at much. I guess what struck me really looking at is, you have a number there, that's 500 million on a cost base of 2.3 billion, so you're saying there's a 22%, roughly, if my maths is right, opportunity there. And my question is, how much of that opportunity do you think is realisable, and over what time scale? And linking to what you said right at the very end there, and what's the sort of implementation approach for doing that? So I identified the prize. What I worry about is we don't then sit there and actually grind away at, well, how do you realise that? How do you capture it?
So in terms of the 500 million, that's split into two key components. The first is 300 million towards avoiding conveyance. That doesn't directly impact on the budget of the ambulance service, which is 2.3 billion.
Yeah. That
would be effective reduction in demand, so that's an allocative efficiency saving. So that's not something you would look to remove from the ambulance service budget, so to speak. That then leaves you with around £200 million for the ambulance service. The largest component of that is again, reductions in conveyance. So if you see a patient and treat them on scene, you avoid the travel cost of going to the hospital and the delay and the handover period of the hospital. So you can recycle that into additional case management. So that's the biggest component of that.
And is that
saving.
a net saving then, or is there a cost in getting to that point, in having, I think as Patrick said, the senior competent paramedics?
Yeah.
So what I'm trying to get to is, is what's the sort of net price here, and then what's the way of getting it?
Yeah. So in terms of the net position, there will be some infrastructure investment requirement. So we've made a start on that with the 30 million allocated to new capital and make ready. And the main trade-off, and I haven't got an MVP I could give you over the next 5 years, the main trade-off I think we're making is the investment in the infrastructure, which releases time on the front line in the context of rising demand of approximately 6% per annum. So that investment is a more efficient way of dealing with that increase in demand over time. I think you're right, though, we do need to do more work on the detailed business cases in the individual elements as this moves forward.
I think also, Richard, that you've got to track this back. If we had things like a standard ambulance, we're going to capture, I can't give you numbers, if we had the technology, and Luke's really important point is, the average time an ambulance waits, this is average, this isn't winter, the average time an ambulance waits in a hospital is 32 minutes. And if you really, in the winter time, when you pile that up, the more we can divert and get people diverted, it's there. And then it's like everything I think we found is that it's, there's a few million on fuel. People actually move to bunkering it as opposed to carding it, and it's a whole series. It's like 5 million there and 10 million there, which we could track through it if we took the view that managerially we use these metrics to track it through.
Our other vendors.
May I also thank Patrick. It's a fantastic report, and I think in many ways it brings the ambulance in the front of reform. I know a little bit about ambulances, probably know it started in the Crimean War. That was the first ambulance. A lot has happened since then, Patrick, as you will have noted.
I thought you were going to say I was there.
No.
We know you've been everywhere.
The thing is also to highlight about ambulance, in my own experience about 10 years ago, is it's not just taking you efficiently to a hospital, including technology, but it's to take you to the right hospital. And that has had a huge impact on public perception. Why am I going to a hospital which is not my local? Because you're going to get a better treatment. In terms of stroke would have been a great example of that. So that changed the mindset of the public that your local hospital may not necessarily be the right one because you're going to go to a specialist unit. So very important. There's another thing which I think worth mentioning is the Royal College of Arts developed what they call the intelligent ambulance, but ambulance with very well thought through, not communication technologies and access to records, but diagnostic technologies to help ambulance to establish a better diagnostic tool. And believe it or not, this won the Global Transport Design Award, which beat the 787 Boeing. It's amazing how design in this country is well ahead of everything else where we are. So I just wonder whether you can revisit that. And the whole idea there, the ambulance service had to commission these ambulances with these designs rather than just buy what is given to them. So just worthwhile revisiting that. I'm happy to connect you, but it won a Global Design Award, which was a very unique thing for UK PLC, but we don't have an ambulance. I think they may have one in India. They commission these. But,
Glynis?
I would also say it's a fantastic report, very, very necessary this time. As part of the work that you did you come to any conclusions about the adequacy of the leadership within the ambulance service? And are there steps that need to be taken in terms of either structure or skill development that are not being taken?
I think in terms of the leadership, as ever, there's some outstanding leadership, but we don't have enough of it. So I think talent development in the ambulance service is really important, spotting the next wave of leaders and getting them in place, I think is really important. And that's a wider problem we've got. So I think we should be doing that with ambulances. I think the structural issues, I mean, one of the questions was, people said to us, well, why don't we have a national ambulance service? And I think our reaction was, we've got enough to do at the moment. Let's make what we've got work effectively, and we do know how to make it work because some people are doing it well. Structurally, on the other hand, I think things like control centres and what the weakness in the system would be is the fact that there are, I think, 22 control centres nationally, and the fact is that if we have a total system failure in one, we can't flip it.
Yep.
And I think we have to be, just as a responsible board, I think in these days of more dangerous times, as it were, I think one of the things we're very clear on, we need to have a good look at actually at the resilience under threat of some of those control centres, because otherwise we just lose the power to deploy. Now 20 years ago what we got was probably adequate. So I think they're the structural things, and I think I think that the sort of final point is this, to return to the point of supporting the staff. Probably this is and I have to say that the missing piece, in the most general terms, I do not understand why we have 20 days. Many jobs are stressful. And I don't understand why we have these sickness levels across the National Health Service totally. And I think, again, it's a point that's incumbent on us to understand that. Because if you look at the combination, if you're, I think, Ruth, at the top of the grades in nursing, I think if you add it up, you get 41 days holiday, including statutories, and you get 20 days sick, and probably 5 or 10 days training. It's a lot of productive time, and the sickness one we can actually manage. And I think understanding that in terms of our national productivity and labour force productivity is something again, I don't want to add to the list of woes of central management, but it's something we probably...
Well, I suspect it's also, I know it's a very strong leading indicator of workforce engagement. If you've got that high a absence rate, you've got a lot of presenteeism happening as well, where people are there but are deeply disengaged.
Yeah.
And it's really important we get to the bottom of it. Ruth, you wanted to come in.
I did, and you gave me a nice segue into it. So thank you, both of you. I like the report. I know that we've been heavily involved in it. Just 3 points. Your recommendations about workforce, I recognise. Thankfully, they're coming out the same recommendations, discussion points as part of our long-term plan on workforce and engagement on that. So stuff about well-being, stuff about bullying, really part of looking after you as an employer coming out. So that's good, it's tallying up. Second, I had the opportunity last week to meet all 10 directors of nursing or directors of quality of ambulance services. Just by chance I was meeting them last week. And they tell me they've got 2,000 vacancies for paramedics. And again, it's something that's coming out as part of the long-term plan discussions, how we want to go for excess supply.
Yeah.
And this is a particular area I really would like to go for excess supply in, because more and more acute trusts, more and more primary care organisations, many more mental health are wanting to have paramedics. So we definitely need to, in my view anyway, recommend that we go for oversupply. And finally, go for your last point, Patrick, around sickness. Absolutely, ambulance trusts in particular have a very, very high, if the highest rate of sickness, and it comes back again to some of that bullying. And we are working with them. We know that we've got that collaborative that has just kicked off around sickness absence.
David and Laura.
Sorry, Glenys.
I
I hadn't finished my answer, forgive me.
No, it was a brilliant answer. But a small technical point. When you talk about the level of illness, days lost through illness, are you using an average figure there?
That's average, yeah.
And the variation around that average, is it large?
Oh, yes.
So you've got outliers that are actually distorting what we understand?
In the rest of the NHS, if you look at sickness in the consultant body and the clinicians, it's like 3 days. Okay.
So you will have long-term sickness.
And then you've got
absence as
the other
that's where I'm going.
Andrew, I mean, you're nodding, Andrew. You did it every day.
There'll be some under-reporting though.
Yeah, yeah.
There'll be some under-reporting in
Yeah.
some areas.
But nonetheless, but to answer your question, there is a very, wide range.
But sorry to interrupt, but what the ambulance sees on it and deals with, at sites of injury, sites of, it's awful stuff, really, really awful stuff. I've seen white faces arrive in A&E, and you just wonder how they've driven the car.
David, you've been keen to
So I think
comment
it's
on the law.
broadly being picked up. I sort of fell off my chair when I read the 20%. I think it's, and I think it's really important to, so I use a phrase in some managing performance, so tough on the facts, open-minded on the reasons. And I think we need to be very cautious about making sure that we understand what it is, because it's the nature of the job, the nature of the support for the job. So to what extent, in the school that I've been involved in, we've provided resilience and mental health training to the kids and to the teachers, because some of the things have been tough they've gone through. And actually, I think we need to think hard about what support's in place, the nature of the job, the nature of constant counselling that's available, all of those type of things, and also leadership, because to your point, this is such a leading indicator of problems. And it may be that we need to provide a lot more support for the leadership as well, rather than leaving them in difficult jobs.
Yes.
And I think the opportunity to take the most difficult area and to see if we can transform it will teach us so many lessons about what we need to do elsewhere. So I'd really encourage us, because I have to say I think 20% is a damning indictment on all of us, actually, because it means there's a systemic problem, not just
You mean 20 days?
sorry, is it 20 days?
Days.
Even so, it's still huge.
Still a lot.
It's a systemic issue. It's not a. And we have to get to the bottom of it and change it.
Laura?
I mean, Davis just made some of the point I was going to, which is it seemed to me that given this is 10, it's almost the first number I've met that's a sort of manageable number of things to get your arm around. And I just thought, therefore, and it's got some of the most severe issues, it would just, how could we use it as a model of actually learning from each other? How do we get involved in that would just really help us pick up that improvement bit of the word and try and use this as a case study.
Particularly in the workforce engagement and
Exactly.
well-being.
Absolutely.
element
So
of
use
the
it,
recommendations.
because it's a small number, use it as a place to try some of that.
Yeah. Kathy, then.
Yes, so I think it's a great report. I learnt a huge amount through it that I didn't know, not least the sheer square miles that they have to cover and the variation in the across those patches as well is considerable. But the bits that I was just going to pick up, which kind of links to what was just being said, is I think those comparison of those factors around bullying, harassment, the sort of staff-related ones is really interesting in terms of being able to actually compare. And I think this will be very useful for our regional teams when they're sitting in front of anyone. In order to support them, you can use the data to do that comparison and say where are things, and then you can think about how you actually provide the change and support. So I thought it was a very valuable potential tool in real time. Using it as we go along, because the whole principle of our model hospital and everything is being able to look at the benchmarking. Where are you in all of this? So I think there's a lot we can get out of this moving forward.
Andrew?
So I just wanted to make a couple of points. The first one is lots of paramedics are going into GP land because it's less stressful. We're not creating the pipeline, so we need to appeal to the school leavers at 16 who if we could give them some employment as care assistant and help them get their paramedic qualification, which takes 2 years, we can get a pipeline. And if we put an advert out that says, come and work in a DGH or a general practice as a care assistant on a band 2 or 3, and we will support your training over the next 3 or 4 years, you will get loads of paramedics coming through. And I think not only do the ambulance service need it, the general practice needs it, community services need it, and actually the hospitals need it. So here's a real challenge here about how we win back the 16-year-olds that we've lost to the health service. So you could have, if you go back a few decades, you could have trained as a state-enrolled nurse with 5 O levels and come in and get supported.
Yeah.
So here's an opportunity for us to appeal to that cadre of folk that leave school, want to come in the health service, but get shunned away because you need a degree to do anything. So
Have you seen my diary for tomorrow then? Because I'm at a school tomorrow in Essex talking to 14
Well, there
to
you go.
16-year-olds
Brillo.
about the health service,
Brillo.
along with a whole range of
Yeah.
clinicians.
Brilliant.
And
Do
the
you have
last
that
point was just one on technology, and that is that we patented something called Lab in the Bag, and you can do standard blood tests with Wi-Fi and 3G connection, and we're trialling in CCAM and SCAS, and I think if we can get that going, there's a real great opportunity here to turn away admissions, because if you can do a simple blood test in the van, right, you can say, right, I've done the check, we don't need to take you to hospital. And it's technology like that that I think we need to put
It's
in.
Laura's point this morning. We've got to lift our eyes to what's possible.
Yeah.
Not,
Yeah. Ian, and then we'll move on.
Yeah, just to sum up, I mean, obviously I won't repeat it other than to say completely agree, this is an extraordinarily helpful report. I'm struck by, I think, Laura's comment about the number 10, and then I link that with paragraph 9 in the report, which suggests rightly that this is an opportunity to create a new common operating model for 10 organisations that provide absolutely vital patient services across the country as a whole. I think it's, it is absolutely about feeding into the regions, but I think it's also pertinent to our new operating model, isn't it? Because I think I am completely struck by, as NHS Improvement, we are committed to helping drive the delivery of high quality care across the country through increasingly applying best practice. And I think, therefore, this settlement between NHS Improvement, NHS England, the 10 ambulance trusts, the Association of Ambulance Trust Chief Executives, is the delivery vehicle for this now that is important and needs to fit in with our operating model. And more importantly, our operating model needs to be able to make that happen. So I think, there's a challenge for us, which we're already working on, to look at the delivery vehicle for this, because I think important though this report is, a report is as important as the ability to deliver it and to actually drive the change. So I think that's the takeout for us and for me as the chief executive, and I welcome it really.
I think that's the key action, isn't it?
It feels like it. It feels like it, because I think the delivery model we're putting in place needs to make this more likely to happen. Working with others rather than to commentate, important though that commentary is.
Yeah, awesome. Excellent. Well, thank you so much, Luke and the team.
Hear, hear.
And thank you, Pat, for leading it. And we look forward to seeing all your recommendations come to be.
Definitely.